Welcome back again. We will speak about part 17 of bladder tumors, lymph node dissections or pelvic lymph node dissection is known as BLNND, performed by lateral lymph node dissection with radical cystectomy. Cancer can spread to the lymph nodes that are in contralateral to the tumor. Thus, pelvic lymph node dissection usually or always bilateral. We have standard and extended pelvic lymph node dissection. A standard have a limit of the dissection are superiorly up to the bifurcation of the lymph nodes up to the bifurcation of the common iliac artery, inferiorly the inguinal lymph nodes, and medially the bladder, and laterally genitofemoral nerve and pelvic side wall. This is the limit of the standard pelvic lymph nodes. Laterally, genitofemoral nerve and pelvic side wall. As you see here, this is the boundary of lymph node dissection in patient with bladder cancer. All these lymph nodes will be resected. So the bladder lie here. We remove the bladder and the lymph nodes up to the bifurcation of the common iliac vein. Okay. Laterally, we have what we call it. Laterally, we have inferiorly, we have inguinal lymph nodes, and medially, you have bladder, and laterally, you have genitofemoral nerve. Genitofemoral nerve lie laterally in this area, and inferiorly, we have ilioinguinal lymph. The ilioinguinal is come like this. Ilioinguinal. Okay, so this is inferiorly. Inferiorly is inguinal ligament, and laterally genitofemoral nerve, medially the bladder. This is known as standard. Standard pelvic lymph nodes remove the obturator, internal iliac, and the external iliac. This is the standard. And as you see here, this is the difference between the standard pelvic lymph nodes is standard. Standard, we remove it at the level of pelvic. This is standard as the bifurcation of the aorta, and the extended, it is reached to the inferior mesenteric artery. Extended superior dissection to the aortic bifurcation to remove the common iliac lymph nodes and may reduce the pelvic recurrence and may improve cancer-specific and overall survival. Also, data are conflicting regard. Therefore, the most guideline stands as standard pelvic lymph node dissection or extended pelvic lymph node dissection may be performed. So this is a standard, and this is extended up to the level of the inferior epigastric, inferior mesenteric artery. Lymphocytes are rare after radical cystectomy because the intraperitoneal approach allow lymphatic fluid to absorb it by the peritoneum. Urethrectomy and orthotopic gallbladder cannot be performed after urethrectomy. After cystectomy without urethrectomy, urethral tumor recurrence occurring up to 10% of the patient, usually within 2 years post-operatively. In female, a risk of urethral recurrence is higher in patients with tumor at the bladder neck. In male, the risk of urethral recurrence is highest in the patients with prostatic stromal invasion, approximately 23%, which is actually poor prognosis, and prostatic ductal invasion, approximately 15%. This is the risk of the urethral recurrence high in this patient, 23% for patient with stromal invasion and 15% for patient with ductal invasion. This is the prostatic involvement in men undergoing radical cystectomy for urethral carcinoma, anterior urethral recurrence, mean and ring. So prostatic urethral mucosa, that's the involvement in the prostate that involving the prostatic urethral mucosa, is 0 to 8% at ring, and recurrence to the anterior urethral recurrence is 5%. So prostatic duct, that's the prostatic duct involvement or prostate involved at the level of prostatic ducts for patient undergoing cystectomy for urethral carcinoma. It is ranging between 0 to 25% at the anterior urethral recurrence involved. or 15% as average or mean. So if the cancer is prostatic stromal in the patient with prostate involvement, who is for patient who is undergoing radical cystectomy radical carcinoma, the range is between 0 to 64, and it is 23% as average for anterior urethral recurrence. Prostate involvement in anterior urethral recurrence undergoing radical cystectomy for a prostatic urethral mucosa prostatic duct, as we see previously, all the percent is come like this with rate. Okay. So perform hysterectomy if any of the following criteria exist. In female urethral carcinoma in any part of the urethra, it is better to do hysterectomy. In male urethral carcinoma in the anterior urethra, urethral carcinoma at the urethral margin during cystectomy based on the frozen section. Okay. So consider performing hysterectomy in patient at the high risk of the urethral recurrence, especially patient not receiving an orthotopic new bladder. Male with ductal or stromal invasion of the prostate is also as option to consider for them. Female with tumor involving the bladder neck. In female who are not receiving new bladder, hysterectomy should be performed because at minimal morbidity to the cystectomy. Hysterectomy decreases the potency rates of nerve-sparing cystectomy. If urethra is retained, perform urethral wash cytology every 6 to 12 months. Place a catheter or a cystoscope to proximal most extent of the urethra. Flush more than 20 ml of normal saline through the catheter scope. Collect the saline as it drains from the meatus. Wash cytology is preferred method of evaluating the urethra of recurrence because it's more sensitive than urethroscope. Urethroscopy may be used as an adjunct to wash cytology. Patients with urethral symptoms, pain, bleeding, tend to have higher stage of recurrence than asymptomatic patients. For resectable urethral recurrence, perform a total hysterectomy. For CIS recurring in the urethra, intraurethral BCG may be utilized. This is survival radical cystectomy, survival after radical cystectomy for urethral carcinoma. This is the pathological stage, and this is the mean disease-free survival range between 5 years and 10 years. So as you see, BT0 and 0, the 5-year survival 92%, and BTA in 0, 5-year survival 79%, and BT1 in 0, 83%, and BT2 and 0, 83%, BT3 and 0, 62%, BT4 and 0, 50%, N1 to N3, 35%, and all stage over all 5-year survival is 68%. That vary between 55 to 75%. And the 10-year survival for BT0, it is 86, for BTA 74, and for BTS for carcinoma in situ with no lymph nodes 89, for BT1 78, for BT2 81, for T3 it is 61, for T4 it's 45, and for N1 to N3 it is 30, 34, and overall for 10-year survival is 66%. So it is near to each other. That's 68%, and this is 66%. That's actually that's here without adjuvant or new adjuvant therapy. This is a 10 years survival. This is the end of this session. We'll meet again in another one. Thank you.